of the inquiry panel. I'm very grateful for the opportunity to give evidence to you on this opening day of this very important inquiry. The Minister and Dr McBride have already, I'm sure, answered many of your questions, but I hope to be able to add and contribute to your deliberations uniquely from a nursing perspective. Mr Chairman, the role of nursing is fundamental to patient care. Nurses are the backbone of the service. When a patient first presents at the emergency department, it is most likely that the first professional they meet will be a nurse, and that nurse will support them through their period in the ED. Each nurse starts their shift with the intention of looking after his or her patients as best they possibly can. The care of the patient is their first priority. Nurses are very privileged in the position they hold, where they provide individual, personal and compassionate care for people when they are often at their most vulnerable. We take our role as patient advocates very seriously, and in order to abide by our code of conduct set by the NMC, our professional and regulatory body, nurses must ensure that this care can trust them, that patients can trust them with their health and well-being. In order to justify that trust, each nurse must make the care of people their first concern, treating them as individuals with respect and dignity. There are many other requirements on them, and in the interest of time, I'm not to proceed with that. I'm guided by that same code of conduct as each and every nurse in Northern Ireland, and I am personally accountable for my actions and omissions in my role, and I must always be able to justify my decisions. As the Chief Nursing Officer, I trust and expect that each and every nurse in Northern Ireland does likewise. Minister and Dr McBride have spoken about the distress and vulnerable state of many patients and their loved ones when they present to the emergency department. They've spoken about the need for those services to be safe, robust and person-centred. And I would add that those services also must be compassionate. This is based not only on the professional nursing expertise, but also my own personal expertise and experience of being there with family. My profession was born from the recognition of the need to care for people and comfort them when they are sick. In fact, the definition of nursing is to assist the individual, sick or well, in the performance of those activities contributing to their health or its recovery or to a peaceful death that he would perform unaided if he had the necessary strength, the will or the knowledge. The role of nursing has changed considerably since I first qualified, taking on new and extended roles, many of which were previously undertaken by doctors. I want to see this expansion continue because it's good for patient care. However, we must not lose sight of the core principles of good nursing care, which are respect, dignity, care and compassion. I am committed to ensuring that each patient and their relative have the best possible care in Northern Ireland. I have visited with Dr McBride all of the main emergency departments, and I know that the staff are under pressure. I know that at times there is inadequate staffing, and I know that EDs in particular are not designed for anything but the immediate emergency care of patients. Nurses have been good at raising their concerns about patient care, and their code of conduct requires them to do so. The Nurse Leaders Network have identified some barriers to raising those concerns, and we're currently working to eliminate those barriers to ensure that nurses who speak out about the standard of patient care feel able to do so, and that they are supported in raising those concerns and be confident that they will be listened to when those concerns are raised. The Royal College of Nursing has published guidance to nurses on raising concerns, and this has given us a firm foundation in order to build. This is something that I feel very passionate about. Nurses, as I mentioned earlier, are advocates for patients and must feel confident in their capacity to speak out when they see that something is not right. The code states again, you must act without delay. If you believe that you, a colleague or anyone else may be put at risk, you must inform someone in authority if you experience problems that prevent you working within the code or other nationally agreed standards. Bearing all of this in mind, my priority as Chief Nursing Officer is to ensure that each nurse in Northern Ireland is empowered and enabled to make the care of patients their first and foremost concern. The RQIA report was very hard reading for me, particularly as the underlying thread was that staff were trying to do their best under very difficult circumstances. I know from talking to those staff that they felt on occasions their NMC registration was compromised because they couldn't deliver the care they believed their patients deserved. This is supported by evidence from the Royal College of Nursing that the single biggest demotivating factor for nurses is not pay or terms and conditions, but the feeling that they were unable to provide the level of care that they had been trained to provide and that they know their patients deserve. I have been working to improve that environment in which these staff work in order to improve patient care, and as Minister previously said, we firstly need a skilled and motivated workforce. It is important that we have the right number of staff with the right skills in the right place, but there can be no excuse for poor care or poor patient experience. One piece of work which demonstrates the department's commitment to getting the right levels of nursing staff is delivering care nursing staff levels in Northern Ireland. Delivering care was approved by the Minister in April of this year, and this document sets in place the role of the executive nurse in each trust as being at the heart of ensuring safe nurse staffing levels. As the Minister said earlier, I am also responsible for patient experience standards, and this is a key component of our strategy Quality 2020. In April 2009, the Department published Improving the Patient-Client Experience Standards document. The development of those standards incorporated a significant consultation and involvement of patients, carers and service users or their representatives. The document comprises of 5 core standards: respect, attitude, behaviour, communication, privacy and dignity. Implementation of these standards is led by the Public Health Agency, and there is a comprehensive programme of work led by the Director of Nursing there. The Department has also established a patient satisfaction survey, a patient experience survey, and this is currently being undertaken at present. The vast majority of respondents to date have felt privacy when being examined or treated was 96%, and that they've been treated with respect and dignity was rated at 95%. Over 4/5 of those who attended the emergency department, 84%, rated their overall care in the ED as excellent or good. A specific emergency department patient survey will commence later this year. The department has also funded the Patient Client Council to develop a set of materials to make the public aware of the departmental standards. These will be endorsed by myself later in the year. The department is also considering the feasibility of a real-time user feedback system. All that I have said sets out the context for the task group which Michael and I are taking forward. I am sure that we will succeed, and I'm absolutely committed and confident by using a quality improvement approach and engagement with staff at clinical and ground level, we can make significant improvements this year. Mr. Chairman, there's much more that I could say, and I'm sure I have gone over my 5 minutes, and I'm happy to take questions.
Thank you, Shan. I will kick off with two. The first one really arises a little bit from what you just told us, and that was that you said that there was a duty, obviously, on nurses to, and part of their code of conduct, to raise concerns, but there have been barriers, and you're working to eliminate those barriers. I wonder if you could say a little bit more about the context of what that is in terms of A&E, and how in practice you will be able to make sure that nurses are reassured that if they report things that they're required to report, that they will be taken seriously and there won't be any ramifications for doing so.
Well, there are systems in place, very clear and accountable systems in place. As registrants on the register, it is very clear in terms of the code what the expectation is. And what I have been saying to nurses really is that you must raise your concern. And if you believe that you haven't got a satisfactory answer at the level at which you raise that concern, you must take it to the next level, and you take it to every level until you get a satisfactory response. Should that mean that they come to see me, I'm quite happy with that, and I've made that known. So there's a very robust process in place. The Minister also issued a letter to staff some years ago in 2012 in relation to whistleblowing. So he has set out his clear expectation. And each Trust Director of Nursing, I know because we have a regular meeting and they have given me their assurances that they are on the ground, that they are talking to staff, that they are promoting the fact that people need to raise their concerns. In addition to that, as I mentioned, the Nurse Leaders Network, we commissioned a piece of work through the Northern Ireland Practice Education Council and the RCN to engage with frontline staff. And they have been out to each of the 5 trusts completing a consultation process, particularly targeted at Band 5 staff nurses. And they've had very fruitful discussions, and I am awaiting the report of that in order to inform us at how we might take forward more progress.
Okay, and if I'll just supplement to that, why do you think it's you've needed to go through those processes and reinforce them, what's been the problem in the first place that's inhibited people from being able to tell it like it is, if you like?
I think that people are working in very pressurised environments. They've got very little time. I mean, there are reports of nurses working 12-hour shifts and not even getting a drink of water. So finding an opportunity to raise a concern is difficult. Actually raising the concern, particularly in relation to a colleague's professional practice, is a very difficult thing to do. And sometimes people can be put off by that. And they need a lot of support to do that. So in a very pressurised system where there's a requirement to provide patient care, and you're maybe not getting opportunities to do other things that you would normally get done in a day, then they put that to the bottom of the list, and they keep putting it to the bottom of the list until things get to such a level that they feel they have no opportunity. I know that some nurses did make representations both internally and externally to their organisation, but at that point they were so frustrated. It was almost too difficult for them to raise it internally in the normal processes that we have. And I suppose the work that we're doing is now supporting and concentrating on the communication processes and how you make that more easily available and how you support staff to do it.
Okay, thank you. I have just one more question, which relates to some of the written evidence that we have taken, and that's from nursing organisations really saying there's a frustration at nursing care has to be available 24/7 and is, but many of the other services that are needed to support that aren't available, both in clinical terms and other ancillary services. And I wondered how much then is that an issue for you, not just in terms then of actually the nursing services themselves, but the other support services that allow your nurses to get on with their jobs?
I think it's fair to say that nursing is probably the only group that has 24/7 contact with the patient on a continuous basis. The other professionals will come in and work with the patient, provide treatment, devise a plan of care, and leave it for the nurses to implement that care. So many of those nurses then, particularly out of hours, find themselves undertaking roles that are not specific to the role of a nurse. And while nobody would have particular difficulty with that in terms of ensuring the patient pathway and the patient journey is smoother for the patient, it does take them away from direct patient contact time. And one of the strands of work that we are taking forward under the emergency nursing framework will be scoping out within the emergency departments what is available, what needs to be available, and how we put in place. That framework is being led by one of our senior nurses in the emergency department. She's also part of the emergency care nursing network. And I have commissioned that work again through the Northern Ireland Practice Education Council, following concerns that the emergency nurses raised with me, both in a meeting and at the Royal College of Nursing Summit. The programme will run for 12 months. It's in 2 phases. The first phase will be the scoping exercise, and it will look to see what is available, what is in place. We'll look at the nursing workforce, the other support workforces that are available, and then the second phase will make recommendations for change. So I think during that process, many of those issues will at least be identified, and some of them will be dealt with.
Okay, thank you. I shall pass you to Marion.
I've only one question. It's on the care of patients and nursing staff. I'm just wondering, could you outline what actions you're taking to forward plan the delivery of emergency health care with a particular focus on patients' experience of the nursing care they receive, and also outline how it addresses the welfare of nursing staff?
Certainly. The Minister and Dr McBride also referred on a number of occasions to the work that's been taken forward in relation to the patient experience. I referred in my opening remarks to the patient client experience standards, the 5 standards which are the bedrock of good patient experience and which are implicit in everything that nursing and all healthcare professionals do. There's also the 10,000 Voices campaign, which is led by the Public Health Agency. It is a particular project that engages the public in telling their story of their experience. And to date, around 5,000 people have undertaken that. The first phase of that project has been in relation to the emergency department and unscheduled care, also looking at minor injuries and out of hours. And the responses from that are, in the main, extremely positive. In relation to nursing care, particularly 92% of those 5,000 people were very positive about the nursing care that they had received. There were very high levels of satisfaction in relation to minor injuries units. There were a number of comments raised, particularly about not knowing who was caring for you, and the feeling that patients felt uncomfortable or unsure about what was happening when that wasn't made clear to them. They also made comments about waiting areas being cold and availability of drinks, etc. So in terms of that and the patient standards and the survey that I referenced earlier, we intend to take forward a framework for the next 3 years, pulling all of this information together, picking out the key areas of improvement, but also the positives from the 3 strands, and developing a work plan so that we continue to engage across those areas, measuring our success, because after each round of observation or analysis of the information, there is an implementation plan developed with specific actions, one of which was around the issue of staff not knowing, or patients not knowing what staff are caring for them. Just this morning I launched the Hello, My Name Is campaign. And the Hello, My Name Is campaign is a campaign which is driven by Dr. Kate Granger, who's a specialist registrar in elderly care medicine, who's also been a patient and is at the palliative stage of her cancer journey, although she's very young. And she has made it a mission of hers to ensure that as many people in health and social care introduce themselves to the patient. So it's hello, my name is, I'm here to do, I'm caring for you today, I'm here to undertake, and before you leave, is there anything else I can do for you? And that simple interaction with the patient increases their confidence in the service, makes them feel more comfortable and more secure, and most importantly is the first interaction and the building block of a trusting relationship between the healthcare professional and the patient. So I think that's very significant work, and direct feedback and direct action as a response of that feedback.
I'd ask also about the welfare of nursing staff.
Yeah.
You had in your comment made in your answer to Chief Commissioner said you were aware of nursing staff who on a 12-hour shift hadn't had time to take a drink of water. I think it is important that we look at the welfare of nursing staff, and I'm wondering what plans you have in place to drive that forward.
Specifically with regard to workforce, the first thing to say is that I'm currently leading the workforce review for nursing and midwifery in Northern Ireland for the next 10 years, which will dictate to us the number of nurses that we need to have in training over those 10 years. Supplementary to that, I referred to delivering care, which is a framework for nurse staffing in Northern Ireland. The first phase is complete, and it focused on medical and surgical units, which would include the acute assessment area and admission ward, but not specifically ED. However, ED is in the second phase, and that will be completed by March of next year. That will then give us a stronger sense of how many nurses there should be on each shift to cope with the demands and the increase in numbers and the increase in attendances at the emergency department. I believe there's no better way to support the staff and ensure their welfare to make sure that we have the right nurses with the right skills in the right place. Another piece of work that I'm taking forward is the advanced nurse practitioner role, and it's about enhancing and utilising the skills of all the nurses in the emergency department, but particularly those who are more experienced and have expertise, so that they can work at a higher level of nursing practice, supporting the medical staff to care for the most complex patients, making decisions about admission and discharge, making decisions about the administration of drugs, the prescription of drugs, assessing patients, referring for x-ray, etc. And by utilising those skills at that higher level, hopefully that will ensure a smooth flow through the department. So it's better for the patients primarily, but it's also better for the staff in terms of being able to see patients more quickly and provide good quality care and rapid access and assessment through the system.
Thank you very much. Similar questions to those that I asked Dr. McBride, but firstly, what, in your professional judgment, what do you think could be done to enhance health governance? Second, I'm not quite clear on something, and it might be that you're not in a position to answer it right now. Maybe an answer can come later, but can I put the question now? We have the RQIA reports, and you have a really important role to play in terms of follow-up and implementation. Dr. McBride outlined some of the mechanisms that are being put in place to ensure the recommendations are followed through. My question is, and I think he said that we're all going to, quote, hold each other to account. I think he said that or something like it, but he can correct me if I'm wrong. I'm interested to know whether or not there's a sort of formal independent element in the implementation measures. Is there a formal independent element in the arrangements to ensure appropriate follow-up to the RQI recommendations? And lastly, and there's a bit of I'm a bit puzzled by something, because it's clear from the RQI reports and other reports that something has gone wrong in some EDs. It's also clear that there are lots of good practices and lots of wonderful things happening as well, but it's quite clear from the material that's been prepared by RQIA and others that something's gone wrong. And you mentioned these really important professional principles, the core professional principles of respect, dignity, care, and compassion. And frankly, they're human rights principles too. You know, they're very closely aligned to human rights principles, which could reinforce your core professional principles. So I'm coming back to this puzzle as to, why not embrace a human rights-based approach, which might possibly, with its emphasis on transparency and accountability and participation and so forth, it might possibly have helped avoid some of the difficulties that the RQIA report outlines. And I just close with this remark, that it seems to be that a good health professional is actually a good human rights worker. And there's this great overlap between the principles you're extolling and the human rights principles. So why not make a human rights-based approach?
Okay, well, I'll take those in order. So in relation to what would enhance health governance, I think we've got very robust systems in Northern Ireland for governance. They're complex. They're never easy, never black and white, always with many variables that affect the delivery of health and social care. Is not similar to designing an airplane in some ways, as Dr. McBride says earlier. In some ways, yes. In some ways, no. They're human beings that we're caring for. They all have individual needs. They all have different complexities, different requirements, different levels of disease, different age, different populations, all of those things that make the delivery of health and social care much more complex. And their governance structures, I suppose, takes account of that complexity in terms of the governance arrangements, which are in themselves, to a degree, have to be, by the size of the system and the services that we provide, a degree complex. I think Sir Liam Donaldson's report and his review will make some very robust recommendations. I don't know what they are. We have just begun that process, but given his level of expertise and his worldwide recognition for the work that he has done in quality and safety and governance, which includes also patient experience, and not for 1 minute because it's Sir Liam, that I would suggest it's purely around safety. I think his report will be helpful in helping us to refine and tidy up, if necessary, the robust structures that we have in place. They are complicated. Everybody's very clear. There is an accounting officer in each organisation. There are specific statutory responsibilities on the executive directors for medicine, nursing and social work at both trust level, at the board and at the PHA. You've got very clear professional responsibilities, as I've outlined, in terms of nursing with the NMC, but also for doctors and social workers and allied health professions. And they all feed into the big governance machine, and all of those are taken account of. So I think we have a very good foundation there. I think that sometimes there's a perception that our governance arrangements are not as effective as they should be, because we get caught in issues like, for example, as Michael referred to earlier, the SAIs and the focus on doing harm. We all recognise as professionals that we don't get it right all of the time, and when we do harm, that we put our hands up. But the process involved for an SAI investigation is about ensuring that that doesn't happen to somebody else, and that we take the learning from that and we share that learning right across the system. And sometimes, with respect to our media colleagues, the reporting of that is unhelpful in terms of creating the culture of openness and transparency and honesty that makes that governance system work well. Your second question then was in relation to an independent expert and an independent role in terms of oversight of the work, particularly in relation to the RQI. And what I would say is that we will be engaging with the public and patient participation at all levels of the task group. Still to be designed, as we're in the early stages of that, but what we have done is to ensure that the PCC are represented at the steering group, and the chief executive of the PCC will be there in some ways as the independent voice and the patient voice, to hold the group to account, to make sure that we represent the views of patients and clients and feed in their experience to that. But we do have more work to do on that, and we will embed that at every level of the structure. Your third question then was in relation to the rights-based approach. And I agree that there are they're almost the same. In some ways, the principles are the principles. Nobody would argue with them. They are the foundations of the delivery of good health and social care by any professional, regardless of their background. From an NMC point of view, whenever we're at the moment rewriting the code, the NMC are rewriting the code, that will be a quality impact assessed against those human rights standards. So it's implicit rather than explicit in all the legislation, in all the standards, and in all the codes that we adhere to.
Thank you. That completes the evidence session. I'd like to thank both of you for very detailed answers. Again, as I said earlier to the Minister, we will welcome any additional written submissions you would like to make. And it leaves me to wish you well in the two of you chairing the task group, and hope that we'll be very interested to follow its progress as it unfolds. So thank you for taking time this afternoon.